Hello all, so this is video 1 for our shock lectures. This video is going to talk about the definition of shock, what's happening to the body or the physiology of shock, and so let's get started. So shock is characterized by impaired cellular metabolism. So basically an injury or incident happens to the body, which sends the cells into an metabolistic phase, and this is caused by decreased blood supply. So we have a decrease in blood supply, and this is going to increase cell metabolism. So our definition. So as always, it's always good to know your definitions. Okay, so it's the failure of the cardiovascular system, and this can be part or whole of the cardiovascular system. So part or whole. So that means it could be just the heart's fault, but we maintain vascular tone, meaning we can still squeeze and contract and constrict our vessels, and we can still dilate them. Or it can be we just have massive vasodilation, which is causing a decrease in blood pressure, but our heart is still working properly. Or it can be the entire circulatory syndrome. Shock is a very complex clinical syndrome. There are a lot of little integral parts that we have to treat and we have to assess to make sure that we can reverse the shock. Which leads us, you need to know that early shock is reversible. The key words are early, and when we start talking in our next slide about the 4 stages of shock, we will find up into what point of shock we can reverse it. Because if we do not reverse shock, it will result in death. Okay? So if we do not reverse shock, it will result in death. Okay? So we have to regenerate cells. If our body is failing, we have increased metabolism, cellular metabolism, our cells are not going to have everything they need to regenerate. So that is why it's so imperative that we reverse the shock early in the stages. And not all cells can be regenerated, such as brain cells. Okay, so the longer that we are in shock, the more damage that is done, especially to those cells that cannot regenerate on their own. Okay, so metabolism, like I said, is increased. So metabolism is increased, okay? So a loss of circulation is going to equal tissue death. And with this loss of circulation, those cells do not regenerate. So again, everything is kind of connected. So metabolism is going to increase. We have loss of circulation. That's going to lead to that decreased regeneration of tissue cells. And remember, cellular death to a certain point will equal death. So these are the 4 stages of shock. We are going to review these on a blank slide in a minute, but here is what you need to know. You need to know the order. So know the order and what happens at each stage of shock. The first stage is going to be initial, then compensation, then progressive, and then refractory. So know these stages, know the order, and what happens. So let's talk about those phases of shock individually. So the first phase we have is initial, and this is going to be talking about the initial injury. So this is when the injury occurs, okay? And a big part of shock is hemodynamic changes that we're going to see. So the body senses those hemodynamic changes. And that is by blood volume. So we're not going to necessarily say blood loss, because it may not be blood actually leaving the vasculature system. So it could be a trauma, which would be hemorrhagic. So we're hemorrhaging internally or externally. It could be massive vasodilation. So we're starting to third space. But whatever's going on is we're losing blood volume, which is going to start, the body's going to notice, okay, our blood pressure is going down. Or we have heart failure where we don't have the squeeze from the heart, which is going to change our pressures as well. So the initial injury occurs. That's the first stage. Okay, the second stage of shock is going to be compensation. So during compensation, it's just what the stage says. The body's reacting to that injury and that sense of hemodynamic change, and the body's going to compensate to make up for that blood volume loss. So we're going to have vasoconstriction, and that is going to try to maintain our blood pressure, tachypnea, and tachycardia, because our tissues have this sudden need for an increased metabolism and increased oxygen demand. And the blood pressure may appear normal. It's going to give us a false sense of security, but that's going to be like the calm before the storm, before we see the patient tanking. During this phase, epinephrine and norepinephrine are going to be released. We want that sympathetic response. We want to maintain our blood pressure. We want to increase oxygenation and taking CO2 back to the lungs. We also are going to start to have a buildup of lactic acid at this stage. So now, as we go to the end of the compensation phase, we're going to have that lactic acid buildup, and we are going to have anaerobic metabolism. Okay, the third phase is the progressive phase, also known as the decompensation phase. So now we are no longer compensating. We cannot maintain our blood pressure. The body's functions are not adequately working. We're going to see a decrease or abnormal respiratory pattern, and just overall loss of consciousness, change in mental status, because cellular death starts. And because cellular death starts, we also have tissue hypoxia. And now we have a rapid increase of lactic acid. The muscles are just not working properly. They are not oxygenating, but they need more oxygen, so their demands are increasing. And this leads us to an increased risk of clots. This is the last phase that can be reversed. So if we don't reverse in this phase of shock, then we end up in the fourth phase, which is refractory. In refractory, the shock is no longer reversible. There's already enough tissue damage and damage to the heart as well and brain that those cells cannot regenerate. There's no coming back, and death will occur. So this wants you to make sure that you understand that once we hit the fourth phase, it becomes unreversible. So the vulnerability of organs. So this is how long the organs can go without oxygen to properly function. So I want you to know how long for each system that we talk about. So the skeletal muscles and digestive system can go without oxygen the longest at 2 hours before we start to see tissue death. The nervous system is going to be 4 to 6 minutes. If we go longer than 4 to 6 minutes, we can have brain death. And that's why it's so important when we're performing CPR to have a decreased amount of time that we're not giving compressions. It's that 4 to 6 minutes, and that's when the brain can't recover. Okay, the kidneys can go 30 to 45 minutes without oxygen. I call them the little wimps of the body. They're very delicate. The nephrons, remember, nephrons cannot regenerate. So once we have nephrons that are damaged, they cannot regenerate, which means that the patient can be placed on dialysis, or if they lose about 75%, they're going to need a kidney transplant. So it's really imperative that the kidneys are being oxygenated and they're doing their job properly. Okay, the heart and lungs require constant circulation. So these are going to poop out essentially before when they have that increased cellular metabolism, that increased oxygen needs, and we're in shock, and they are going to go into the progressive phase and then refractory just before the nervous system. So the heart and lungs need consistent circulation. So that's why respiratory arrest lead to a code so quickly, because they both need constant circulation. Shock will always, 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 always lead to death if left untreated. And it can happen quickly. It can happen anywhere from the beginning of shock from 30 seconds to 48 hours, like I said earlier, depending on severity. So, someone who is in a major car accident or there's a major penetrating wound to the trunk, they're going to go into shock quicker than maybe someone who has had an infection and then it goes to a systemic infection and then it goes to sepsis. And we're going to talk about that in a later video. Sepsis may progress slower depending on how severe the infection is. Okay, these are just general symptoms and signs of shock in general. So each shock is going to have symptoms that are similar to all the other shocks, and then they're going to have signs and symptoms that are specific to that type of shock. So being able to recognize these symptoms are going to help you say, hey, I think something's going on with my patient. Trending is always very important in emergency and critical care medicine. And just recognizing something's not right here. I need to order different tests to see what's going on and bring it to the attention of the team, because sometimes somebody may not notice something that you do. I am a big advocate of having more than one set of eyes on a patient when something doesn't feel right. It doesn't mean that you're not catching something or you don't understand what's going on. It never hurts to get a second opinion. Okay, so some general signs and symptoms. Be able to recognize these, be able to list these, and pick them out in case scenarios or patient scenarios. So anxiety is going to be a big one. That is your body's way of alerting you when something happens to you. Something just doesn't feel right. Chest pain, especially if it's a heart issue. Chest pain can be radiating, it can be tight, it just doesn't feel like something's right. Shortness of breath as well. Cool, clammy skin. So the first sign of a hemodynamic change or shock is going to be cold, clammy fingers. So cool, clammy skin, when you go to check capillary refill, and normal capillary refill is 2 seconds or less, and you feel that their hands are cool and clammy, that's because their body is shunting all their blood volume that they can back to the core to perfuse those vital organs. So even before you see a decrease in blood pressure, you're going to see a decrease in cap refill, you're going to see an increase in cap refill, and you're going to feel cool, clammy skin. Decreased urine output. So our body's naturally going to say, hey, there's no fluid in this system. The blood volume's decreasing. We want to hold on to everything that we can. So looking at our patients as a whole is very important in critical care and emergency medicine. We should be focusing on more than just respiratory. We need to take those blinders off. Looking at their I's and O's. Good RTs are looking at their charts and reading their notes. So I's and O's are going to be important for us because the cardiovascular system is so important to the respiratory system. They're very much entwined. Pallor, so a change in skin color. Sometimes it's described as dusky, pale. So their skin may look pasty. All of these are going to be signs of shock. Cyanosis, we can have central or peripheral cyanosis depending on the shock etiology and what stage of shock they are in. a rapid pulse because they're trying to compensate. So this is going to be mostly during the progressive phase, or the compensation phase before the progressive phase. So it's trying to compensate. Shallow breathing, unconsciousness. So it could be unconsciousness or altered mental status, decreased consciousness. So unconsciousness is going to happen when the brain says, okay, we just need to focus on our basic body functions, and we need to breathe, and our heart needs to beat. Weakness, our muscles aren't going to be able to react the way that we want them to. They're just trying to perfuse. Hypotension, dull pupils, which means they're going to be, or they could be sluggish to react before they stop reacting at all. Overwhelming thirst. So an overwhelming thirst is going to happen because the body wants more volume. It's naturally craving. It's going to tell you, I need to drink, I need to intake because something's happening with my blood volume. And then nausea and vomiting. Okay, we are going to go into causes of shock. So we're going to talk about general causes. We're going to review a chart and how shocks can overlap each other on the basic cause. And then we are going to go into specific kinds of shock in the subsequent videos. Okay, so the three general types of shock is, first we have heart failure. So that's also known as pump failure. So the heart itself is failing to pump blood out to the body. So we still have the blood volume. So this would be part of the circulatory system isn't working. So that would be the heart failure. And we'll talk about cardiogenic shock in the upcoming videos. Then we have absolute hypovolemia. So this is volume blood loss. So we have actual blood loss. So think about blood leaving the system. Blood is leaving the vasculature. So this could be, we have a trauma patient come in and we see blood all over the trauma bay floor. We can also have hypovolemia that we don't see, right? If we have a type of internal bleeding, or we have a GI bleed that hasn't made itself very clear yet, it's blood actually leaving the vasculature system. And then we have relative hypovolemia. Relative hypovolemia is also known as distributive shock, and this happens from massive vasodilation. So back in cardiac A&P, when we talked about fluid being able to leave the vasculature, this is what's happening with that massive vasodilation. The integrity of the vessels have now stretched to allow that fluid to leave. If too much of that fluid leaves, our blood pressure is going to decrease. Our heart's going to have to work harder. And if our heart is working harder, then it's increasing its metabolism. So it's imperative that we find the underlying cause of this relative hypovolemia and correct it. So know these three general causes. You're going to need to be able to list under each more specific cause as we get into that, what the general cause is. Is it a heart problem? Are they actually losing volume, blood volume, or is it a relative hypovolemia? Okay, so this chart comes from a study where I got most of this information from for shock. For your reference, you can find it in the resources section. I highly, highly recommend that you. Okay, so this chart comes from a study where I got a lot of the information from for this lecture and this PowerPoint. It is in the resource section, and I highly, highly recommend that you read it. So this is just putting kind of what we've been talking about the general causes of shock into an image, so you can physically see what we are talking about. So you can see here, we know that shock has an increased demand at the tissue level and a decreased oxygen supply. Our body tries to compensate until it can no longer compensate. And then as we move out, we see that there could be an output problem or a volume problem. We have, and within those areas, with an output problem, we have cardiogenic, which is a pump failure, or obstructive. So meaning something's blocking the heart from pumping the blood out to the tissues. And then on the volume side, we have distributive, and you can see it says shift here. So massive vasodilation. And then we have hypovolemic, where we're actually losing blood volume. So distributive, we have a shift. Hypovolemic, a loss. Cardiogenic, again, is cardiac. It's a pump problem. Obstructive, there's something outside the heart that's preventing pumping. And then that's divided up into those quarters. So we are going to talk about neurogenic, anaphylactic, and septic. It's going to be a distributive issue. Hypovolemic, we have hemorrhagic, traumatic hemorrhagic, hypovolemic, and traumatic hypovolemic, which we will talk about. Cardiac, we have cardiac myocardial pump failure, so heart failure, brady and tachycardic arrhythmias, insufficiency, and then decompensated stenosis. And this out here is going to tell you what part is causing that. And then preload, afterload, and then right side of the heart. We're not going to focus on this too much on this side in this class. We talked about that a lot during cardiac, and then we're going to talk about that again once you get to your hemodynamics class. So we're going to really focus here on distributive, hypovolemic, and cardiogenic. Okay, these are the specific types of shocks that we are going to go into in the next set of videos. I just want to review the three basic types of shock, the general types that are associated with each of these types of shocks. So you have to know this. So hemorrhagic shock is absolute, right? We're losing blood volume. Neurogenic is going to be a relative or distributive. Cardiogenic is going to be a heart problem. Psychogenic is going to be relative. Septic is going to be relative. And anaphylactic is going to be relative as well. Well, that is the end of this video. So before you start the next one, take some time, review your notes, create a table, whatever's going to help you study and understand these basic parts of shock.